So we start the following outlines, which will be read by our colleague. I hope you listen.
So then we also talk about follow-up, which is very necessary in clinical care. Then we'll talk about our references. Okay.
Before the diagnosis of diabetes, I want to assume that most of us here are doctors and we know the definition of diabetes, what it is, the prevalence of diabetes, both in Nigeria and Africa and the whole world. So let's not waste our time talking about all this. I'm sure diabetes, you know what it is, and want to get straight to the point so that you won't waste time. But if you have questions along the line, I will take us back. There's no problem. We'll take your questions. So, like my colleague will be taking the slides, I'll make our comments along the line. Okay. Please keep your questions, clarifications.
So there are various methods for us diagnosing diabetes mellitus. We usually want to know what the fasting blood glucose is, and also our postprandial blood glucose and random blood glucose. And currently, in standard practice, our oral glucose tolerance test is not typically used, routinely used for diagnosis, just in patients that have borderline arrangement in glycemic control, or patients that have gestational diabetes mellitus. And the WHO criteria for diagnosing diabetes currently, as 1999, for patients that are symptomatic, as patients that present with symptoms, you only need one single fasting blood glucose, usually above 126 milligrams per dl or 7 millimoles per liter. Or in the patients that is asymptomatic, or for the random blood glucose, you need when the blood sugar is more than 200 milligrams per dl and 1 millimoles per liter. So this is very, very important for us to remember as for patients that are symptomatic. However, patients that are asymptomatic, you have to repeat the blood glucose again to ascertain diagnosis of diabetes mellitus. So you can't just use one reading to make a diagnosis. You have to actually repeat the blood sugar again. Then for other patients and other things that we could use for diagnosis, we have the C-peptide autoantibodies. We know that type 1 diabetes involves when there is no insulin production. So we usually typically want to check C-peptide levels and also our autoantibodies, which can result in type 1 diabetes. So the other concepts for us to just take note of is the pre-diabetic class, which includes both impaired glucose tolerance and impaired fasting glucose. So currently, for impaired fasting glucose, once the blood sugar is between 6.1 to 6.9 millimoles per liter, we say that the fasting blood glucose is impaired. While for the 2 hours post-glucose, once it's less than, usually, once it's between 6.1 to 6.9, we talk about impaired fasting glucose. Then for impaired glucose tolerance, usually, impaired glucose tolerance, the range is once the 2 hours postprandial, that's post-eating or post-glucose administration, is between 7.9 to 11 millimoles per liter. We talk about it being impaired glucose tolerance, and the fasting blood sugar usually is less than 7. So that's for impaired glucose tolerance.
Okay, so what he's trying to say here is, we say this is care of diabetic patients. So in your clinic or various places of work, if you see a patient with a fasting blood glucose of greater than 7 millimoles per liter, you should find out if the patient has symptoms And most times they have osmotic symptoms, which include polyuria, polydipsia, weight loss in this patient. So if they have such symptoms, at one test, you can ascertain that the person is diabetic. But when, for instance, the patient comes in just on a routine investigation and finds out that the fasting blood sugar is better than 7 millimoles per liter, now you ask questions, there are no family history of diabetes, there's no weight loss, no polydipsia, no polyuria, no polyphagia in this patient. At that point, you cannot make that diagnosis. That's the patient to come back and you repeat the test. And if you still have better than 7 millimoles per liter, that patient is diabetic. But now, you have some situation where the patient will come in and you do a fasting and say 18 millimoles per liter. Please, the patient is diabetic. You don't have to wait for family history or second time to do that, to repeat the test to make a diagnosis. So that being said, so we should look out for patients that come to clinic routinely and do fasting for them on RBS. And I promise you, you will pick up diabetic patients randomly because the prevalence is becoming a pandemic now. So now we are going to talk about what is involved. We're not treating diabetes. I want you to understand that. It's when you see a patient and you make the diagnosis of diabetes, how do you follow this patient up? How do you take care of this patient in your clinic? How do you take care of this patient when they go home and when they come for follow-up? That is essence of this presentation. And at the same time, we tell you one or two things to do for this patient. And if it's getting out of hand, please seek for expert management. But at the same time, you should know what and what to do. So my colleague will take us through.
Okay, so the first part that we always want to emphasize in medicine is a patient-centered collaborative care. So this is a situation whereby when you are consulting a patient that has just been diagnosed with diabetes and you want to evaluate or propose a particular treatment measure, you always want to listen to the patient. So you have to actively listen. And when you actively listen, you have to assess things like their preferences. There's some patients that prefer, due to maybe past experience with a particular drug or previous complication, prefer a particular medication or just anything. It could be anything, but actively listening is very, very important to assess that. And also by listening, you need to ascertain patient's literacy level, how educated the patient is. Because that will give you some idea in giving instructions. Because the educational status or educational level of the patient will make you understand. This patient will be able to easily understand what I'm going to do to pass across. And also from listening, you'll be able to know about their barriers to care. So there are some patients that for one reason or the other, they don't really have supportive system around them. So they won't be able to easily adhere to treatment. So you know that you have to prescribe something for them that is easy for them to adhere to. So these are why we emphasize patient-centered care in managing patients with diabetes. Okay. So like we mentioned, this presentation is going to be holistic, talking all about from diagnosis to investigations to treatment to follow-up. So we talk about it in this following way. We're going to, yeah, when a patient comes to your clinic and you are initially consulting that patient, you want to first confirm how you're going to confirm and classify diagnosis. We also want to listen and examine, evaluate the patient for possible complications. So we all know diabetes is a multi-systemic illness, can affect the renal system, can affect the brain, can affect the heart. So you also want to ask patients for questions, symptoms, you want to receive that in patients, and also possible comorbid conditions like hypertension in them. So it's very, very important. And also, you want to, if the patient is a known diabetic, you want to know what the previous treatment was on. For example, patient has been on insulin before, has been on just oral anti-diabetic drugs, and also risk factor control. So we want to ascertain for patients that are at risk of the coronary artery disease, for example, or patients that are at risk of a peripheral artery disease. So by evaluating patients, we want to form that. And also, you then be able to develop a management plan for this patient and develop a continuing care. So these are just some of the points that I want to just elaborate on.
Okay, yeah. You see, what we're trying to say here is you as a doctor make a diagnosis of diabetes in the patient. It lies on you as a doctor to initiate treatment in this patient. And now, by doing that, you first of all need to communicate with the patient. When by communication, you need to the patient needs to understand what is actually wrong with the patient. And by doing that, you listen to the patient. First of all, understand what the patient even knows about diabetes. Then, with that, you now try to give the patient knowledge of what the disease is all about. It's very important because that first contact is usually what the patient holds on to. By this, I mean, if you don't convince this patient of what the disease is all about, he will easily be swayed by different people and different talks. By this, I mean, someone will come and tell him that somewhere you can go and treat diabetes and he goes away, you believe the person. Now, if you don't tell this patient what the disease is all about, how it is managed, how people can live with it, these people desperately looking for treatment might go to places that they'll be swindled and made complication worse by giving them concussions and everything. At the same time, some might start doing prayers and everything, waiting for the diabetes to go away. But this education is very, very, very important. It's very, very, very vital in treatment of these patients. You need to understand it. If you don't educate these patients, you will definitely lose these patients. They'll come down with complications that you cannot be able to manage. So when you communicate with them, sit down, listen to them, what they've been through, what they know about it, what they can talk about it, what they can discuss outside about it, and put them in the right direction. With that, you started managing this patient. That being said, you need to confirm your diagnosis, like you said. When you confirm this diagnosis, in part of taking your history, you are supposed to find out if there are possible complications this patient must have developed. Because most times, people come down with complications before they present to the hospitals. They might even come unconscious, most especially for type 2 diabetic patients. So before they come, they must have one or two problems which they have sought help one or two other places. But you as a doctor will try to make you understand that this is diabetes and it can be managed. So with that, you try and address the issue of complications if it has. At the same time, have some comorbid condition that can exist with diabetes, in which you also need to address. If patient has been on treatment before, review the result, the treatment, you have investigation done before, you go through it, and now try and tailor your treatment according to the patient. Please, there's no cast on stone that the patient will use a particular drug. If this one works for the patient, matter of convenience, affordability, availability, please go with that. The outcome is better patient care and better outcome. And always don't forget that the management continues even after seeing the patient. So continue.
Okay.
So you're going to go through some particular things you must need in your medical history, investigations, examinations, possible complications patients can have, and at the same time, possible ways to manage them. So,
Okay. So I'll just be going through some pointers, things that we should note to ask the patient when we are taking medical history. So it's very, very important to know the age and the characteristics of onset of diabetes. So knowing the age gives you some guidance, even the diagnosis of diabetes. So at what age were you first diagnosed or at what age were you first having symptoms to give you some information. Also, you also want to ascertain the patient's eating pattern because that will give you some guidance when you are going to counsel the patient on nutrition. So you want to know the carbohydrate content in their food on a daily basis, how much vegetables in their food. So this eating pattern is very, very important. Also, you want to know the nutritional status of the patient. So typically in some patients, like patients that are type 1 diabetic, you can present the clinic with severe weight loss from polyuria and the like. So you want to know the nutritional status of the patient, whether they are eating well, weight history. Also, you also want to know what the patient's sleep behaviors is like. If the patient is having a regular sleep pattern, because it gives us helps in prognosticating this patient. And you want to look at the physical activity or habits of the patient. So there are some patients that have their jobs or by nature of their lifestyle are physically active. So you know that that will be a positive stigma kind of them. And generally nutritional education from the history. So prior nutritional education, have you seen a dietitian before? Have you been given nutritional counseling before? And also you want to ascertain presence of comorbidities because diabetes typically presents with multiple comorbidities already, especially if the disease has already been advanced. So you want to know, are you hypertensive also? Have you been having chest pain before? Do you have a difficulty when you walk? Do you have pain in your legs? Or do you have difficulty in your vision? So these are some things that can give you an idea or comorbidities are already present in this patient. And you want to screen for psychosocial problems because it's very important and can be a barrier to management. So you want to know the kind of living state. So a young man, you want to know whether he's married or how many children he has, what is your occupation, your income range. This will give you some idea. Even the drugs, when you have prescribed some medications, what do you need to afford. Then last but not the least, you want to ascertain for history of tobacco use, alcohol, and substance because this is a cardiovascular risk factor. So diabetes is a cardiovascular risk factor, and the combination of all this tobacco use, alcohol consumption, and substance use can worsen the cardiovascular status of the patient.
Okay. Like I said, in the medical history, there are specific things you need to find out. And taking history is very, very important. It gives you an insight on the type of diabetes the patient is dealing with. Age is important. It gives you an insight if you're dealing with type 1 or type 2, or that different forms of diabetes. Characteristic of onset of diabetes, this one particularly is circumstances surrounding the development of diabetes. First of all, our family history, that gives a pointer as the more of type 2 than type 1. Then people on steroids, history of taking steroids, obviously can develop, because the patient develop diabetes. People that have had surgery, pancreatitis, other conditions, thyroid disease, these are the conditions that you need to find out. Does this patient have all these surrounding things? Is it actually the cause of this diabetes in this patient, or just administration type 2 diabetes? So I think you need to find out so that it will help you in management of this patient. If something is causing it, you stop it from there to take management. Now, eating pattern can be two ways. You know, the visuals and then those that are the poor people. And the visuals, obviously, they eat excessively. It is not a problem. But now, for the paupers, not these paupers, as in the lower status, they are more into carbohydrate food than other using protein. Like, for instance, the visuals, obviously, they use meat, they can use 3 pieces of meat, 4, 5. But obviously, the those socioeconomic people concentrate more on carbohydrate food and less of protein. So you can imagine the outcome of those that have family history of diabetes. Now, at the same time, physical inactivity is becoming a part of us these days, and we call it living the life. Where somebody wakes up from an AC room, enters an AC car, goes to an AC office, and sits down and presses remote controls. Now, you can call it the big life, but at the same time, it's kind of a sedentary lifestyle whereby there's no break of sweat on your body, no physical activity to burn any form of calories in your body. It becomes a problem. So, that being said, the patient, if the patient has any habit of exercising himself in any form, it's very, very important. And it's part of your management because advising the patient, you need to burn some calories, you need to do some physical activities. And at the same time, find out the possible presence of comorbidities in these patients. These comorbidities can be in form of hypertension, can be in form of cardiac, coronary vascular disease. All of these things can coexist together. And at the same time, you can also have other thyroid diseases coexisting with diabetes at the same time. So you can address it one after the other. Like I said, this is care of diabetic patient. We're not talking about treatment of diabetes here. So this your history must be so encompassing to contain everything needed in managing this patient. Now, after that, psychosocial problem is very, very vital. People believe diabetes is village people. Some believe he was sent, some believe, so many beliefs. So he needs to address such concerns. Because if you don't address such concerns, no matter what you do, he believes somebody sent it to him, will not do anything about it. So you need to address such concerns. And also, social lifestyle, alcohol consumption, tobacco use, and substance abuse are also not good in diabetic patients.
So other things we also want to find out from our history is diabetes education, self-management support and needs. Also mention the fact that you want to know the previous patient's treatment regimen. So patient has been on metformin or been on insulin. You want to know what exactly patient has been using. And other medications too for other comorbidity situations. So it will help you to know what possible comorbidity situations in the patient and response to therapy. So it's very important. The patients that have been previously checking their HbA1c. It gives you an idea of their glycemic control. So you also want to find out from the patient what their home glucose sugar has been like. Have they been checking it? What the values have been? So that's also very important. Then, patients that have previously had complications before, you want to know about the decay, frequency, severity, and cause. So this is very important. Although in our environment, we know that many times some patients might not be able to give you that information easily. So if they are coming from another center, it's always important to ask for a report or a referral information so you can have an idea about this. Then also hypoglycemia, because one of the most common complications or fail to pick up easily in diabetics is hypoglycemia. So you want to know how frequent is the hypoglycemic episodes? Are they aware when these episodes happen? Because awareness gives you an idea whether they have an autonomic affectation too. And also you want to assess their medication taking behaviors and their barriers to adherence. So you want to know, is this patient someone that is adherent to medications on a routine basis, or is this someone that is not really adherent? So these are some other things that you have to find out when you're taking your history.
Okay, like you said, the idea of this presentation is after this, you will manage a diabetic patient like a boss. That's the idea of this thing. So, all this being said, we're talking about patient education. It is very, very important and key in the management to avoid you dragging a patient with babalawos and pastors. If you don't educate your patient, they will not comply to your medications. Like you said, previous treatment, you have to find out what they've been doing and what they have done. Records of investigations to help you. And also, always discuss complication with your patient, most especially DK, what's going to happen to them if they don't take their medication. Don't shy away from it. You have to ask them. If you don't take or tell them, don't take this drug, look at what's going to happen. They're going to have what you call diabetic ketoacidosis, whereby it can be unconscious, it can have some level of breathing problem, it can lead to death if not managed. So with that, we're not trying to scare the patient, but at the same time, we tell the patient these things can be avoided. You know what I'm saying? You have to make people understand that it's not as if you can't have this, but it can be avoided, and it can be avoided by compliance to both the drugs, exercise, and their feeding pattern. So with that, you can leave. I always tell my patient, under my watch, my patient's up to 150 years, and that is the way it is, and that's the way it's supposed to be. So the idea of this thing, for you to approach this patient like a boss, and they won't have any problem. Then also the issue of hypoglycemia is also supposed to be a problem because if you don't educate on hypoglycemia, they will not know. And at the same time, these patients might enter into hypoglycemia not knowing. And you know the complication not coming back from that hypoglycemia, permanent brain damage. And also, you have to actually educate them on this complication and how it comes, the method of presentation, which I'm going to talk about along the line of presentation, and adherence to medication and treatment.
So, for physical examination is very important in patients with diabetes. It will help you to also ascertain possible comorbidities, possible complications. So, some things you want to know, anthropometric measurements. You want to know what the patient's height is, what the patient's weight is. And by knowing this, you're able to safely calculate their BMI. So, by knowing their BMI, it gives you an idea. It's also a prognostic factor in them. And also for children, especially people that type 1 diabetics, you want to assess their growth pattern and their pubertal development. So you all know that diabetes, especially ones that poorly controlled sugar, can affect a patient's growth and also his pubertal development. So you also want to ascertain what baseline is on your first interaction with them. And also blood pressure. One of the most common comorbidities with diabetes in our environment is hypertension. So blood pressure is very paramount. You want to know what blood pressure is. Then fundoscopic examination. This should be a routine, especially at initial visit and initial review of the patient. Because like we are going to mention in our further slides, one of the complications of diabetes is diabetic retinopathy. It can affect the eyes and the vision. So you want to just get a fundoscope and look at the eyes and assess for what complication is already present in this patient. And also examination. Diabetes is a multisystemic illness. I've said that several times and I'll continue to say it. It can affect anywhere in the body and can also affect the skin and cause some complications. So skin examination, visualizing and just looking at the skin will to give you some idea of how the patient's glycemic control is. And also foot examination. We'll also go further into talking about what you need to do for the foot in patients. So comprehensive foot examination, you want to look for ulcers, you want to look for deformities and the rest.
So, still on physical examination, like you said, you must examine your patient. No matter what you're just talking about, you must examine your patient. And this BMI we are talking about, central abdominal obesity is our greatest problem in diabetes, where they think, as a big man, my belly must be. So, as it's getting big, you should know that I'm getting nearer to insulin resistance. So, that's it. And then blood pressure should be determined most time because type 2 diabetes is synonymous with high blood pressure. Now, the question, how does it even happen? So now with type 2 DM, we have what we call hyperinsulinemia, so due to resistance. Insulin is everywhere, not even enough to do this thing. So that hyperinsulinemia causes increased glomerular filtration of sodium, and that will give you high blood pressure. That is the pathophysiology of high blood pressure in type 2 DM patients, why it's commonly found in type 2 due to hyperinsulinemia, glomerular activity, and sodium reabsorption. Yeah. Can have other complications from maybe renal impairment, but before then, these things develop and because of hyperinsulinemia. That's it. So we always need to check the blood pressure, control the blood pressure, and reduce the capillary pressure, the glomerular pressure, sorry, in diabetic patients to avoid any form of diabetic kidney disease. Fundoscopic examination, we don't do it. Most times we don't do it. But I'm telling you now, as a boss, you must always do fundoscopy. If you don't know how to do fundoscopy, please refer the patient to where it can be done. But simply, you can always examine for changes in the listing, in the retinal changes. But like I said, if you don't know or you can't differentiate, please always send for fundoscopy. Not when the patient now start telling you that, I cannot see again or something, you now start going, no. It's supposed to be a routine as part of management of someone presenting with diabetes. You don't have to wait for the complication to come up because eye change is a particular, is big, a lot of biggest complications and because of blindness in Nigeria. And if you've not seen such cases, they are there. People have it. People have glaucoma, people have cataracts, all from diabetes. Because the hyperglycemic state distorts the lens. So you really have to do fundoscopy for this patient to find out if the eye changes has gone to any particular stage. Now, skin examination is important. There are also many skin changes in diabetes. You have what do you call it? Glucose versus lipodiga. You have acanthosis nigricans for insulin resistance. You have hemopathy. These are things you can have, and it should be addressed because it can't be managing diabetes and managing complications. You have to manage it so that the patient becomes comfortable in totality. Now, comprehensive food examination. I tell my patients that a needle, what do you call it, or toothpick injury, to me is as bad as ST elevation as a cardiologist. That's true because we lose patients from diabetic foot, and unfortunately, it's multifactorial. If the glucose is not controlled, these people develop peripheral artery disease and neuropathy. A patient can match nail and have it on his foot for 3 or 4 days without even knowing if the neuropathy patient has. So with that, it can lead to complications. It can lead to osteomyelitis. It can become 4-foot gangrene. It can become a whole foot gangrene, and this thing leads to death in this patient. So please, it is very, very important. Ask the patient to keep a leg, look at it, check for position, the much you can do. Like I said, as a boss, you must check for sensation in this patient. We're going to talk about it more along the line of our management. So lab investigations, they are basic. Even if patient does not have money, there are basic investigations you must do for this patient. What I mean basic, you must do basic for this patient. Fasting lipid profile must be done. Serum creatine electrolytes must be done. EGFR must be calculated, because these are the things we talked about. A patient might be presenting for the first time with diabetic kidney disease in type 2 DM. A patient might present for the first time with diabetic retinopathy. A patient might present for the first time with an MI. So you must do all these things and find out if there's any end organ damage in this patient. Have a baseline for your investigation, for your treatment, and you now work on it, whereby you now repeat it quarterly, 6 monthly, 1 year, depending on patient's compliance. This must be done. HbA1c gives you an insight of what the control has been for the past 3 months. Now, for type 1 DM patients, thyroid function test needs to be done. Why? Because autoimmune disease, which also similar to type 1 DM, autoimmune disease, most of them they can coexist. Also, other investigation, why I actually put this one is I don't want to fill area of investigations. I put this one because this one the basic you must do. Diabetic workup, you must have this one done. After that, you can do an ECG, you can do a full blood count, you can do abdominal ultrasound to check renal, you can do all those ones. But if a patient, depending on where you're practicing, and the patient is seeing you for the first time, they must have these baseline investigations. Must. And with that, you have a baseline for you to start your treatment. So that in the next 3 months, if you check it, if it's declining or if it's worsening, you know what you're doing. And also it affects the medication you give. For someone that has diabetic kidney disease, and some drugs you need to avoid. And someone that has hyperlipidemia, there are also drugs you need to give and cancel the patient. For HbA1c, as we know, you have to manage postprandial glucose excursion. So that being said, please, this investigation should be done. And like I said, you need to manage the patient like a boss.
Okay. So moving over to lifestyle management. This is very important, sacrosanct management of patients with diabetes. So first things first, we're going to talk about diabetes self-management, education, and support. So diabetes self-management and support just involves patients being involved in their care. And when patients are involved in their care, it brings about a better outcome in management of them. So all patients with diabetes should ideally participate in their self-management education and support, both at diagnosis and thereafter. So like I mentioned, it helps, it improves patient outcome, it improves their health status, it improves their quality of life, and we should be patient-centered, we should be respectful, and we should always want to ascertain what our patient's preferences is, which will give us an idea in guiding our clinical decisions from time to time.
Okay, continue. I'll make
So we are going to talk about, like under lifestyle management, we're also going to talk about nutrition. For that slide, we'll just basically go, like I explained, as well as managing, for me, managing the patient's glycemic control or managing the patient's blood sugar, nutrition is very important. It is one of the most number one things that we should always consider in patients. We also always want to promote and support them. We want to promote and support healthy eating patterns, and we should emphasize on them eating food that are nutrient dense, nutrient, and their portion size should be appropriate. Should not be eating large portions, which will end up leading to better improving their health. So ideally, patients with diabetes they should have a particular weight goal, a BMI goal. So they should be in a particular weight and a particular BMI. We'll talk about that as we go on. Then also, we also want a particular glycemic, blood pressure, and lipid goals. So it's by their nutrition, what they are consuming, that will lead to all of this, like glycemic blood pressure and lipid. And also it will help in delaying and preventing complications that might arise from diabetes. So we always want to give them their nutritional counseling based off on cultural and personal preference. So depending on where the person is from, what part of the country, we all know that particular part of the country likes a particular dish, and they have dishes that are custom to them. So even our soups, we always want to counsel them based upon that and help them to make these changes. So we are going to provide emotional support, counseling, and also nutritional counseling for patients with diabetes. So the next slide is just highlighting what typically should be content patients with diabetes should consume. And this is just going to say that any refined sugar, it should be a drastic reduction. So by refined sugar, we talk about sugary stuff, talk about sugar, our soda, and all like so
juice, mineral,
all those things are actually it's even better we stop. Drastic reduction, complete
not
stopping.
You
have to stop it. Then their nutritional, what their food, their caloric requirement per day. So we talk about the complex carbohydrates. You know, in Africa, this part of the world, our food is carbohydrate based.
They must swallow something.
Everybody must swallow something. You know, rice is a complex carbohydrate. So that should just contain 50% of the caloric requirement per day. The typical complex carbohydrates, things like rice, things like yam, things like swallow, eba, salmon, like it should just be about 50% of the total calories per day. Then always want to emphasize the need for fiber. Fiber diet, high fiber diet is very important. It's important in the bowel movement, important in general health. So it's very, very important. And also protein should then make up about 10 to 20% of the total caloric requirements per day. Then the remaining
not 1% of one piece of meat. No, in Africa, it happens that the father of the house eats 4 pieces of the meat, and then the child that needs the protein more than the father give it 1 piece. I don't know what it means. But meanwhile, we need protein up to 10 to 20%. So that's what you're talking about here. The same thing with the fats, then salt intake, moderate, low intake. Discourage overweight, obesity. But now, like he was saying initially, medical nutritional therapy is the first line of management of diabetes patients, which includes the dieting and what the patient takes in. It is very, very important and ideal that you educate these patients. Unfortunately, type 2 DM patients are older people, and changing lifestyle is usually a big problem. What I mean a big problem in the sense that someone is used for the past 40 years of his life, or 45, even 60, 70 years, not them to stop it. It becomes a problem, but we keep on trying. There's no cast on stone rules of how to do that. You just try to encourage the patient and let him see the good side of it if you actually adhere to these things. And you should understand that no matter how you advise these patients or counsel these patients, when they leave you down their own and they do what they want to do. Now, what the reason want to do is the way you spoke to them. Like I said, this doctor was so emphatic about this thing. Don't eat fufu again. You understand? But when he gloss over it, the patient assumes, well, he doesn't know. You are the one that is supposed to make the patient understand that this one is not good for you. This one is good for you. And make you understand with empathy. I understand that it's difficult to do all these things. You're not going to be shouting, you must not, no. One told me, I'm 89 years old, and they're telling me, what do you want me to, I don't understand, what am I living for? So, but these are things you need to find out, that you need to make you understand that we still want you around. Your family still wants you. Why can't you have a way of reducing distance? This is the way to go. And with this, we're able to convince the patient to understand that these things are not good and we want you around. But when the approaches are emphatic and authoritative, and patient is elderly, we tell you, I know when they give birth to you, what are you telling me? You understand? And We're not listening to you. So you find a way to make them understand that feeding should be improved, but not in a confrontational manner. Please, in a way that you understand is difficult. You're all human beings, you want this, but at the same time, it is good you stop this and add this so that you live long for us. We really want you to be around. And like I said, under our watch, patient stays long, and you must approach this patient like a boss.
Okay. So another advice generally for
Physical activity is very, very, very important. Very, very, very vital. Please, if you're not running, you're walking. If you're not walking, well, don't crawl. Just you jog.
Just be active, yes.
You need to be active, please. We need to be active to burn calories. We need to be active to reduce insulin resistance. We need to be active to enhance glucose uptake. Exercise causes transport of glucose transporters to the muscles, and it absorbs glucose. That's why exercise is good. Understand? Please, it is very, very important. You need to go through the requirements for you.
Yeah, so some of the recommendations by the American Diabetic Association, the typical recommendations. So for children with diabetes, children that have just been diagnosed with type 1 diabetes, we usually recommend at least 60 minutes per day. So we all know that as a child, children are very active and they move around. So physical activity could be one of their physical activities. At least 60 minutes per day is okay for them. And for patients with adults, now we're talking about adults now, which is reflects most of our patients age group, those with type 1 and type 2 diabetes, the recommendation, and I'm going to just emphasize this so you can counsel your patients appropriately in clinic. The recommendation is 150 minutes per week of moderate to vigorous activity. So when we talk about moderate activity, we don't talk about strolling. Moderate activity involves activities like cycling, like jogging, and vigorous is like running, swimming, you understand? So, or cycling. But so something has to be moderate to vigorous, and it should be done at least 3 days in a week. And it should not be more than 2 days, 2 consecutive days without exercise. So please, this is very, very important for us to emphasize to our patients when we're counseling them about lifestyle measures. When you're counseling them about diet and about physical activity, you have to emphasize the fact that 150 minutes per week, you understand? That's over at least 3 days. So 3 days in a good week is good, and the activity should be moderate to vigorous in terms of intensity. Why for patients that do shorter, so you can also counsel them to do, if the patient is doing a vigorous intensity exercise like running or intense jogging, then you can shorter the, or carrying with strength training. So the duration is now shorter, minimum of 40 minutes per week. You understand? So adults also are advised to perform some form of resistance training, 2 to 3 sessions per week. So resistance training, I know some of us that go to the gym, we know what resistance training involves. Things like banding, that you can stretch, all those things are also very important. It's a form of physical activity that will help.
So, like we said, please, you're not going to Olympics. It's just to keep your body active. And with that, you're going to help us help improve. And like I said, the glucose transporters are improved in exercises and causes glucose absorption. So it also improves resistance. It's very, very, very key in management of diabetes patients. And make sure you advise them, because these executives that move from car, like I said, fly private jet, do all this, is you are living the life, but at the same time, you are losing the life. That is it. At the same time, you are losing the life. So park your car, take a walk, but please be careful that if the environment is safe. They start looking for you. Park your car. Easy. But unfortunately, in the country, when you reach there, they will asking you, how I put your car. You don't have a car. It's not even supportive, but we don't mind all those things again. What we are looking out for is for ourselves, please, and our patients. We should exercise. We should exercise. Encourage the patients to exercise. What they can, they have estates now, working in estates. You don't have to go so far. And now you can jog if you want to. You can go to the gym. So that's basically that. It is the part of management of this person, which you must emphasize for this patient, after which you now go to the glycemic targets and other investment targets you need to achieve in this patient. Like I said, we are not treating diabetes, it is the care of this patient and their follow-up.
Okay, so we're moving over to glycemic control, and it's very an important part of our presentation because it should be at the back of every health care provider, the doctor, and the patient himself. The patient should be aware because it's going to be a patient collaborative kind of care. So, how do we get these primary techniques that we use in getting our glycemic targets? One, patient self-monitoring of blood glucose.
Very, very important. It is very, all patients must have glucometer. All, no matter of optional, they must have a glucometer, and you must emphasize for them that the need for the glucometer, not they must. When you say need, maybe not thinking maybe if it's important or need. No, they must have their glucometer for self-monitor of blood glucose. And what it means that the patient takes control of his blood glucose. The patient will always know when this is not a matter of I'm feeling headache, I'm feeling, you do your RBS at that point, know what it is and know what to do. It is not very expensive, they can afford it. So please always encourage them to have their personal glucometers for self-monitoring of blood glucose. Very, 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 very vital.
Okay, so as well as the self-monitoring of blood glucose, another value we use is the A1C, that's the HbA1c, glycosylated hemoglobin. It's a very important marker we use for monitoring patients with diabetes because it gives you an idea of the longer term, usually 3 months. So it's very important for our patients. So recommendations, the worldwide global recommendations for patients, diabetic patients, we should aim to perform at least the HbA1c test. We should aim to perform it at least twice annually. And this is for patients that meet their treatment goals and have a very good glycemic control. So these are patients that you see in clinic and you see their fasting sugar. Fasting sugar is very less than 6 millimoles per liter. So you are confident in them. So you can look at doing 2 HbA1cs in a year for them.
Or HbA1c that is correct and good within range, you can now extend it to other 6. But if it's out of range, please bring it out to quarterly or 3 monthly, please.
So that's what our next point is, performing it quarterly with people that are not meeting their glycemic goals. So quarterly or 3 monthly, very important. And we are talking about as medicine advances and as our care improves in our country.
People can even do point of care at home now. That's what I'm talking about now. Point of care is not something that is so cumbersome now. Something you put your sample, put your list and press it. So they can even do HbA1c. Although now we have glucometers that can plot graph for you over some time, which you ask them, they'll tell you, I want to call him. There's nobody, I'm not supporting anybody. Just get a very good glucometer for yourself.
So our point made is very responsible for an adult diabetic not to have a glucometer at this current. So please, we're emphasizing it.
They should. You as a doctor must make a patient have it so that when they come, even if they don't come with a chart, if they come with a glucometer, he has a record. You go to it and see what control has been. The patient might not just be taking the drug and take it just a few days before it comes to see you, and you see 5.4. Meanwhile, if you go to the glucometer, you'll be seeing 11 points, 14 points. It happens every time. So please.
So for our blood glucose, I mentioned it earlier about what we aim, our targets, glycemic goals in adults. The fasting blood sugar should be less than 6 millimoles in clinic. We want to be seeing less than 6. We don't want to be seeing 6.5. Understand? We want to be seeing less than 6.1, less than 6 for the fasting. Why postprandial? As I just finished eating, we are aiming for less than 7 or less than 140 milligram per dl. So in whatever you use in your center, if you use milligram per dl, is 140. If you use millimoles per liter, is 7. Then for the HbA1c, that's the glycated hemoglobin. Ideally, the normal is less than 6.5. But for diabetics, our target is less than 7%. So a diabetic patient that has 6.5, we can attest to the fact that okay, that patient has a very good control. This is an idea. So for lipid profile, and it's very important we know these values and keep it in our head. The typical values we aim for, their targets in lipid profile. So the triglycerides should be less than 150 milligram per dl. I hope you're able to remember this. while the LDL cholesterol, which we tag as bad cholesterol, should be less than 100 in diabetics. Total cholesterol target should be less than 150 milligram per day. So just try to memorize it and try to know it. Triglyceride total cholesterol less than 150, while LDL less than 100. And for the HDL cholesterol, we aim for more than 40 males and more than 50 in females. So for blood pressure control, so the international standard, what the target is less than 130 over 80 millimeters of mercury. Systolic less than 130, while diastolic less than 80 millimeters of mercury. Then the BMI, our target is within 20 to 25. That's a very stringent control, but for diabetics, you have to make all these stringent rules so that you improve their cardiovascular health and glycemic control in the long term. And their waist circumference, aim for less than 100 in males and less than 88 in females. Okay, so over to something that is very important, and I'll just leave it for Chief to talk about hypoglycemia.
You're talking about complications you must explain to this patient. And hypoglycemia is very, very important. So we need to talk about the clinical classification of hypoglycemia, because you have cases where patients will come to you and telling you that, doctor, when my sugar is 7 millimoles per liter, I'm feeling hungry, my body will be shaking, my hands will be sweating, everything. But when I check my glucose, it is 7. What is happening? These are questions they ask. Some will tell you that they don't feel anything, check the glucose, you see low. Meanwhile, they're not even feeling anything. So these are the questions they will pose for you. And this is a type of hypoglycemia that you need to understand. So that when you have such cases, you don't have to be worried, you don't have to be disturbed, you know what the problem is, how to now follow it. Now, probable symptomatic hypoglycemia is when the patient has symptoms of hypoglycemia, which is sweating, as you know, tremulousness, hunger, headache, dizziness, all those autonomic symptoms. Now, these are signs of hypoglycemia, but there's no actual test of blood glucose to ascertain if this patient is hypoglycemic. We call it probable symptomatic hypoglycemia. In such situations, we also treat the patient, knowing fully well that probably it might be hypoglycemia. But now, this is what we're talking about, patient having a home glucometer. At this point, you don't have to be second guessing or talking of probability. You do a blood glucose test and it shows immediately that this patient has low blood glucose and we intervene appropriately. Documented symptomatic is when the patient has the symptoms I discussed before and you do their random blood sugar and it's low. It means that the patient is actually hypoglycemia documented. Now, you have what we call asymptomatic hypoglycemia or hypoglycemia unawareness. This is a common finding in patients that have tight glycemic control. When there's tight glycemic control, the body adjusts itself. By tight, I mean someone having 3.8, 4.1, 3.0, within that range of very tight control. Now, what happens? The body adjusts itself to that very tight glucose level. What will happen? Due to the fact that it's tight and the low part, there is upregulation of glucose transporters to the brain. Without upregulation, you have more glucose transporters moving glucose into the brain to maintain the body at that low glucose level. Now, what is the implication of this? What happens is when the blood glucose now drops from that 3.9 to 2.8, when you start getting those symptoms, the body will have enough transporters moving the glucose into the brain, not now boycotting those autonomic responses, giving the patient hypoglycemia, meanwhile it's still walking around. Symptomatic hypoglycemia unawareness. It continues until it drops to 2.1, where the patient now becomes comatose and it becomes a problem. And recovering might be difficult depending on where the patient actually had the problem. So in managing your patients, it's good to have good glycemic control, but usually it's not good to have tight control. So now how do you manage this patient? What do? You try and release the control from that 3.9 to allow you to go up 5 points. At this point, 6 is okay. Now, when you have this control go up, what happens? The body on its own tries to adjust to that new glycemic control, which is the normal one now, by reducing the glucose transporters and maintaining what is supposed to be maintained, and patient becomes okay. Now, the relative hypoglycemia is like the opposite of the unawareness. Now, people that are used to high blood glucose every time, 13, 14, 13, 14, for quite a long time, what does the body do again? The body tries to adjust to that high glucose level by doing what? Due to the glucose is excess and it's taking so much to the brain, it downregulates those transporters that move into the brain. Now, when it downregulates those transporters, the body adjusts itself to that glucose level as the normal glucose. Now, when it now move from that 14 or 13 to, let's say, for instance, 7 and 8, the transporters are not enough to perfuse the brain with this glucose. So what happens? That patient starts having symptoms of hypoglycemia because when you don't get enough glucose, it now sends to the body the signal that I don't have enough glucose. What's happening? It's hypoglycemia, irrespective of the glucose control the patient has. So in such people, they will come down with features of hypoglycemia at 6 and 7. And they'll be telling you, doctor, they're confused. They don't know what's wrong with them. Small thing that is tired, you should not be alarmed. Like I said, yeah, this approach is like a boss. You know what is happening to the patient now. It's relative hypoglycemia. Now, how do you approach it? It's a very simple thing. You don't drop the glucose so rapid that way. It's a gradual drop. Your target at that point not to achieve good glycemic control immediately. Your target at that, depending on how long it has been hypoglycemic, your target at that point is to gradually drop the blood glucose, allowing the body to adjust to the new glucose level and not seeing lower glucose reading as hypoglycemia. You move it from 12, 13 to 10, from 10 to 8, gradually and until achieve your target. If not, the patient will be having this complaint and it's a regular. I'm sure one or two of you must have heard this complaint, and I'm very sure now you can know what the cause is. Severe hypoglycemia is when the patient cannot help himself. If the patient is unconscious, nobody's help, you need a second party to come and do random blood sugar for you and give you glucose for Wipotriad to take effect. So with that said, this thing can be managed. Or hypoglycemia, move it, can be managed. First of all, another thing I want to advise is, please, if you have a patient you are managing for hyperglycemia, for instance, in the ward or your clinic, and it happened that probably there was an overzealous insulin approach or whatever giving you hypoglycemia, please, if the patient is conscious, it's very simple. Allow the patient to take the sugary content, maybe a bottle of Sprite, bottle of Coke. After that, eat food. The idea of going to hang 10% in a conscious patient and moving the hypoglycemia now to hyper 300 or something becomes an issue. All the effort of trying to drop the blood glucose now is futile. You now start trying to walk it back to this thing, normal blood glucose. Please always give the patient something to take if he's conscious. If not conscious, you can do your glucose supplementation. At the same time, you can give glucagon, but in patients that are chronic alcoholics and those with liver disease, please do not give glucagon because there's no glycogen score for them to produce glucose from. That's contraindicated in these patients.
Okay. So I've spoken about glycemic targets. I've spoken about some complications, hypoglycemia, which is common one. And we're moving over to pharmacologic approach to glycemic treatments. So it's going to be quite brief because we are all professionals and we actually have an idea on what to do. We're just going to talk about the recommendations and what should be the standard. So first things first, for the recommendation for treatment of patients with type 2 diabetes, metformin is first line. So metformin is the preferred initial pharmacological agent for patients with type 2 diabetes.
Because it increases insulin sensitivity.
Yes, increases insulin sensitivity, there's low risk of hypoglycemia and also low risk for weight gain. So it's the number one initial pharmacological agent. So anybody that is just initially being diagnosed with diabetes, we should take note of that. Then also we should learn to consider insulin therapy in patients that are newly diagnosed but are markedly symptomatic or having markedly elevated blood glucose. So you meet a patient from clinic with a sugar of 300 milligram per day, please don't withhold insulin therapy. You can actually start insulin therapy at that point in time. Or another thing is the A1C. Getting A1C of above 10, maybe patients with 11, sometimes you see patients with 14. So please don't withhold starting insulin therapy. I know in our environment, so many patients have their reservations with starting insulin, but with appropriate counseling, making them understand what insulin does and how it will help in bringing the sugar as markedly as initially as possible. So we should just take note of that. Starting up metformin as initial pharmacological agents and putting consideration for insulin therapy in patients with marked symptoms or elevated blood glucose. So for non-insulin monotherapy, once you have achieved your maximal dose of metformin, and that in our environment, typically that's 1 gram, 2 grams in a day, 1 gram BD, 1 gram in the morning, 1 gram in the evening. Once you have achieved that and you have not achieved your target blood glucose, which is fasting of less than 6 or HbA1c of less than 7, you want to now add a second drug. So for our second drug agents, we have different options. We have a table that will show that up. Usually we talk about sulfonylureas, we talk about DTP4 inhibitors, we talk about GLP-1 agonists, or adding a basal insulin. So you should just take note of that. First line, metformin, then when you're not achieving targets, you want to now add a second option. So always use a patient-centered approach. The patient-centered approach is very important because it gives you an idea. So, for example, patients have reservations, maybe financial considerations. There are some medications that are more expensive than some other ones. The SGLT2 inhibitors, that's the empagliflozin, dapagliflozin, that's the new therapy market, can be very expensive. And some patients might not be able to afford that. So you want to listen to those kind of patients and opt out for something like a sulfonylurea like metformin. And like I mentioned, we shouldn't delay starting insulin in patients in order to achieve our glycemic goals.
Yeah. So what you're trying to say in effect is that please, when you start treating a patient for diabetes, you should aim at good glycemic control and you have to throw in everything you have. And initiating insulin is very, very vital. The problem in the environment is insulin, they believe, is the final
destination.
If you try insulin, you are already dead. It means that diabetes is not curable or treatable. So their own is the worst diabetes. Please, I want to ask you, try and disabuse such thoughts in people's mind. I think you understand that insulin is even the first line if you're supposed to, you want to rest the pancreas. But the issue now is insulin is a serious problem in the environment. Before you convince a patient to take insulin, you have to, I don't know, but in the end, the only thing is that when they ever start it, they won't stop. But starting is where the problem is. If there's need for that, please always encourage them. And you have different forms of insulin now. We have once a day, 2 times a day, 2 times a day. So obviously, and they work. In terms of cost, really, this GLP-1 now, that's the problem. Incretins are the problem we have now. That is this the popular one. Always semaglutide. They're all talking about now that they are used for weight loss. I don't know. The drug is more of weight loss than diabetic control now. Everybody is looking for Zempic. They are incretins, GLP-1 agonists. So if your patient can afford it, who are you not to? Please prescribe for the patient and let them know that consistency is, you're not just buying the first one. But if they can't afford it, you have other alternatives. But the major aim here is, like I said, look at glycemic control and preventing complications. So with that, always try to initiate insulin when there's need or the insulin. Moving on.
So this is just our table highlighting.
Just please look at this table. You're not going to be emphatic on it. Like I said, all treating diabetes, all the care you're talking about. With this algorithm, you can find out how to approach your patient. And like we said, there's no cast on stone on these things. You tell your patient according to what they can afford, what is available for them, and what is good for them, please. So that you, in the end, will get the good glycemic control you're talking about and prevent complications in this patient. If they can afford Ozempic, give them. If they can afford Ramipride, please give them. If they can afford Dabzin, and so on, give them all these things. Don't have to hold it back. But where the problem is that someone that's not eating food, they are telling to go and buy divorce meds. That's what the problem is. So that tells you, so I'll buy this drug, I'll not eat food. So no work is done. So that's just the issue here. Please tell your patient now, go through the chart, gives you a guide on how to approach the patient with some side effect that you might see with it and know how to go about it.
Okay. So this is just talking about
the same thing I'm talking about
therapy.
the therapy. Please, it is not a threat. Please, not a failure of this thing. Diabetes, not the worst diabetes ever, and not punishing the patient. Please, patients keep on telling us, and whenever I say, my sister, her diabetes is not finished. No, it's not like that. It is for the patients better outcome. And they do very, very well. These are regenerative hormones. It places some things in the system. That's the way it works, personally. Please always encourage them, if need be, not only when they're in coma, if need be, before coma, have.
Talk about one point there, self-titration for patients. So
yeah,
the dose is not sacrosanct.
Patients can let them know that at the particular point you can remove 2 or add 2, depending on what the glucose is given them. Those especially those on short acting, what we call basal bolus regimen.
Okay, so we're going over to our final part of our segment, and we're talking about complications. So I'm just going to first highlight our complications and how we usually classify it typically in medicine. So we start about the vascular complications. Vascular complications can be microvascular, affecting the small vessels of the body, or they could be macrovascular, affecting the large vessels of the body. Then we also talk about the neurologic complications. Then other things that could affect could be skin, could be eye, could be bone, could be joints, could be pregnancy related. So like I've been saying, diabetes is a multi-systemic illness. It can affect everywhere in the body. So for the microvascular, we have 3 microvascular components. Talk about retinopathy. So that's affecting the small vessels of the eye and can lead to visual loss. So many times in clinic, we meet patients that have already been at the far end of some of these complications. Patients will come and complain about visual loss, that they can't really see well. Most of the times because of the blood sugar, the glucose accumulating in the retina and affect their vision. Diabetic nephropathy. This is one of the most common causes of end-stage renal disease in our environment. Some patients already come down with diabetic chronic kidney disease before even presenting. So that's even what their presentation is, nephropathy. So we should take note of that. Then neuropathic complaints. Some patients might have peripheral neuropathy. They have pins and needle sensation in their legs, or they can't feel any sensation in their legs when it has progressed. So you should take note of that this affects the small vessels. Then the macrovascular. So diabetes can affect the big vessels of the body, and it could lead to things like stroke, and lead to things like ischemic stroke. It also affects the coronary vessels and lead to myocardial infarction. Also, the peripheral vessels, peripheral vascular disease, and cardiomyopathy. So, we also talk about the peripheral neuropathy. They can affect some of our nerves of our body. Even the cranial nerves too can also be affected. And the autonomic neuropathy. So it can affect virtually every part of the body. So some of the autonomic neuropathic symptoms that we should just look out for are things like postural hypotension. So it gets to a point whereby change in posture, maybe patient is lying down, patient tries to stand up, is noted significant drop in blood pressure, and patient will collapse. Also, impotence sometimes might be the presenting complaint in some patients.
Yes, basically, erectile dysfunction is actual, but in totality, impotence, bringing in so many things. The patient will tell you that he's having an erectile problem, he cannot have good erection again. That is what you need to ask a male patient when they present. Because if you don't ask them, they assume you're not a good doctor. Most times it's what are bringing them, what bringing them to the hospital, not even the diabetes. And I'll tell you, so is there a way out of this thing? Now, the approach is this. There's supposed to be a way. Depending on the level of damage the excess blood glucose has done. If it's within limits, glucose control reverses everything. But if it has been a continuous process you have been with for long and medication has taken place, nothing will do, nothing. So always and always ask the patient, male patient, about ED, which is very important. Address their issues for them so that they will happily take their drug. If not, it becomes a problem. And they start seeking help everywhere. Social media is full of all of fallacies, unverifiable things that even you know go that far. So please, we are battling with a lot of things. Social media, people side talk. Are battling with the pastors. I don't even take out the pastors. But now the issue that when they follow them in a very hook, line, and sinker that they even stop taking their drug, no problem. So you need to make them understand, educate them the way these things are. Because if not, desperate measures for those desperate time can lead to very, very, very severe complications in these patients.
So moving over to talk about other complications of the skin. So the patients with diabetes can come down with diabetic dermatopathy. So we see a lot of skin lesions in them on their skin, and then it's patients with diabetes that this can come down. Then there's what called microbiosis lipodica diverticorum. I wish you had a picture. It's part of the skin complications for diabetes. And infections. Diabetes can actually lead to immunosuppression and put you at risk of commensal organisms and
The excess glucose does a lot of things.
it does
We have different patterns of these complications, advanced medical end products, polyol pathway. So these are the different forms of ways it can affect, causing what we call these leukocytes not being able to fight
against infection.
So the immune system drops down and you're able to all sorts of infections. That's why, like I said, good glycemic control makes the patient comfortable and live normal life. And I always say, under our watch, we can live up to 150 years.
Yes.
And we must approach this patient like a boss because they are in charge. So you can avoid all these things on time.
So I've mentioned some of the eye complications, cataracts, patients, cloudy eyes, you can't see well because of visual field. Glaucoma, increased pressure in the eyes, can result as a result of diabetes. Even diabetic ophthalmoplegia, so the optic nerve which can be affected by the sugar, blood sugar. So also talk about some musculoskeletal complications, duplicity contracture. You see the fourth and fifth digits of the hand contracting like this, and also pregnancy-related complications. Patients that have gestational diabetes can come down with recurrent third trimester pregnancy losses, recurrent abortion. So you keep wondering, why am I losing my pregnancies in the third trimester? So this could actually be as a result of diabetes. And also, you can also come down with polyagerminous. You can see the liquor volume being large, infertility, fetus can be macrosomic, congenital malformations, and hypoglycemia. So these are some of the complications that we typically expect in patients that are diabetic. So we're moving over to our final part to allow Chief to talk about foot care. Very important in clinics.
So basically, the foot care I talked about before, that a needle prick injury or toothpick, to me, is as serious as any elevation ever to cardiologist. I keep on saying this thing, but people laugh at it. Please always inspect your person's foot. At least check for pulses. If pulses are there, there's always pelvis. You can check for posterior tibia. At the same time, if not anything, use a 10G monofilament and check for sensations at the pressure point to know if they are resisting. So basically, foot care is very important. Advise the patient, please do not walk around barefooted. Always wear a slippers, most times a sliding, not wear tight-fitted shoes. Take care of your foot. Don't use sharp objects in cutting your nails so that you cannot injure yourself. You can use simple nail cutters and everything. Always examine the foot for anything. And if there is any, or a patient presenting to you, or eventually a patient has any form of bullet that ruptured or saw or matching anything, please do not go to a chemist shop. Come to the hospital, and when they come to you, you know what to do. Proper antibiotics, foot care, good glycemic control. And if, for instance, the patient has amputation before, that's foot at risk already for the other leg. If a patient has any deformity, any calluses, charcoal joints, any pes planus, any form of loss of hair, dryness, all these things are risk for our foot at risk for risk factors for developing diabetic foot in patients. So please advise them when they have injury on the foot, do not use any local concussion. Some even use hydraulic, some use engine oil. Please, all those things are out of place. It worsens the condition. They should do all these things, and they shouldn't do all these things, sorry. And they should make sure they report to you immediately. And when they report to you, that's when you, as a doctor, will manage it like a boss. Antibiotics is very important. Ensure that there's good perfusion in that place. They will do a Doppler of the foot. At the same time, good glycemic control is paramount. If not, that wound will not heal. Advise them there's nothing like the match poison for village. It is the problem they have. They argue with somebody, and when they go home from their village trip, after eating everything in the village, you are having things on the leg. You now say that Mr. So put poison, but not like a match of poison. I see it every time. They keep on telling you that the match poison, not poison, it is diabetic neuropathy, depending on the type of patient is presenting with. Because that's symmetrical, what do you call it, peripheral neuropathy. The patient tells you that that's why he's walking on foam. The leg is doing sensation at that point. So they look at you like matching on foam or matching on physics. That's how they describe it. Know that this patient is having diabetic neuropathy. Address it immediately. Give drugs that can relieve pain if they have serious pain. Give something that regenerate the nerves if you can. And at the same time, they should have proper foot care, especially wearing tight, loose fitted shoes and sleeping slippers. Don't allow them walk around barefoot. That's where the problem is. Walk around barefoot, neuropathy can have a nail on the foot for 1 week. You don't know. So with this, always emphasize on that foot care. We neglect it most times, and people come. When they have wound, they go and take us off concussion, and when they come, they already can bring us. So these are avoidable things. These are things that can be avoided. Please, I'm asking you as a doctor, please, diabetic foot is a serious issue. We've lost colleagues, we've lost patients with diabetic foot that are mismanaged somewhere else. And we need to actually start addressing it on time. Examine for peripheral pulses, check for sensation. Those stages are not expensive. Have it on your consulting table, put the leg. Yeah, put the leg, apply it there, and let the this thing, filament buckle. After to close his eyes, with that, you will know that this patient not feeling anything. At those pressure points, those places. And it happens, patient don't feel anything. That's where it starts. If you have the ability of the ankle brachial index, wonderful, you can do that. If you cannot, send patient for Doppler. It is very, very important.
So moving over to the final segment, concluding part of our presentation. And I hope everybody is still following us. I've talked about comprehensive medical evaluation. I've talked about glycemic targets. I've talked about lifestyle, nutrition. I've also talked about pharmacotherapy. And I've talked about complications. So just what to do when we are following up patients in our clinic, on our wards after being diagnosed. So all patients after treatment, be it in the ward or clinic, you should be counseled. It's very important that patients are properly educated. Just take out time and explain to them that diabetes is not an acute illness, it's not malaria, it's not typhoid. It's a chronic condition and it will need continuous care and follow-up. And typically, after initial diagnosis, we want to aim at a short appointment. Typically, we aim for at least 2 weeks. And during those 2 weeks, it's important that the patient has records of their self-monitoring their blood glucose that they are doing at home. That's at least a daily fasting. So it's highly responsible. I will just emphasize it again that a patient that is diabetic doesn't have a glucometer because you have to know what you are even managing. So always counsel them on the need to have a glucometer. So when they are coming to clinic for follow-up visits, they come with their blood sugar readings. Then we now study these charts. It helps us to assess if our medications are actually doing the appropriate thing and gives us an idea in adjusting dosage or even adding on additional medications. So this is what we need to do. So we then ask about patient's compliance. We want to know if the patient is compliant with therapy because sometimes you see a patient in clinic and you think that the sugar is not getting better, but it's just that the patient is not taking their drugs.
And they'll claim they're taking their drugs. That's the point. They'll claim. Simple question: how many drugs do you have remaining before you came in? Say I have 4. What does it mean? Patient is not compliant. That's pill counting is the simplest way to catch these people. They'll tell you they're taking their drugs, and you'll be struggling. You have the food, glycemic, anti-diabetic, and the patient not. But
so you take our time to talk about feeding too. Hope they are making some adjustments to their diet. Hope they have sticking with the proper diet plan. And also physical activity. Is patient exercising as recommended. Then you want to now address any new or any previous lingering complication. For example, maybe there's a small ulcer on the leg. You want to look at it and see how it has progressed or whether it's getting better or just other complications. Patient already has some form of chronic kidney disease or diabetic nephropathy. We want to look at the kidney function at that current visit to just follow it up. Then always take out time to emphasize on food care. Always take out time during any clinic visit to counsel patients on food care because, like my chief has emphasized, a needle prick injury to a diabetic patient is synonymous with ST elevation in mind cardiology. So it's very important to talk about foot care. So we don't want patients wearing slippers, those typical slippers that people wear. We don't want our patients wearing those rubber slippers. We always want them to buy a mirror that they can use to look at the back of their leg every day. It's very important to let your patients know about that. Then you possibly take care of any comorbid conditions. And the most common one I'll talk about is hypertension. So if patients are hypertensive, you also want to look at the blood pressure in your clinic visits and make sure that the medications are controlling the blood pressure adequately because hypertension and diabetes, they're like brothers and sisters. They interact and they negatively impair the patient's health. So if patient's blood glucose is not better, if the glycemic targets are not being met, you don't want to give that patient a short appointment, typically 1 to 2 weeks, depending on how bad it is. So, but always make sure you give that patient a very short appointment so you can see the patient again and recounsel. You always have to note that you are recounseling at every clinic visit, you are emphasizing things to patients. And if control is better, you cannot aim at giving long appointments. You can give a month, you can even give 3 months. People that they have been seen over time and have good glycemic control. Then we want to aim for we want to do some routine checks, which is the renal function, HbA1c, and lipid profile. This should be done every quarterly, every 3 months. You want to check it. Make sure that your patient has done a repeat of their kidney function, their HbA1c, and their lipid profile. And in case a patient is going back to their home state, let's say, for example, patient came from Delta State to Abuja for care, you want to then prepare a medical note stating all that has been done, all the investigations, so that There's continuity of care, because many a times that's another problem we have in our patients. Continuity of care is not good. So please, every medical professional should take out time in making out a detailed note if patient has um, let you know that they are going to another place or they're even transferring out of the country, for example. So always and always, last but not the least, on final note, advise your patients that diabetes is not treated, but managed. There is no cure for diabetes. There's no magical cure. There's no magical herbal concoction that you drink. Always emphasize to these patients, diabetes is not treated, but managed.
Yeah. Thank you very much. I'm sure this last part was very self-explanatory, and thank you very much for joining us. The idea of this presentation, like I said, to manage diabetes like a boss. So with all these things, I'm very, very sure that we will be able to manage these patients accordingly, follow appropriately, do food care, give good glycemic control, improve lifestyle, and have a very good outcome. So that patient will tell, this is the best doctor I've seen. That's the idea. And under your watch, a patient will live at least 150 years. So I tell my patients. So thank you very much. So there will be room for some questions and clarifications, and so I've not seen questions. Initial people that find difficult to join said consumption of enough sugar can cause diabetes. Emmanuel Jonah is asking if consumption of enough sugar can cause diabetes. By enough, I don't know what you mean by enough, but sugar is still sugar. I always give my patients this narrative. Someone that has family history of diabetes is seen like a Mercedes Benz. And nobody that has family history of diabetes is a Hilux pickup. Now, if you decide to carry firewood with Mercedes and Hilux pickup, which one will break down? What I mean by is this sugar you're talking about, taking sugar. Now, the endangered species person that has a family history of diabetes already has a family history of diabetes in the gene. And the other person that is not in danger, no family history, is the Hilux pickup. Instead to carry firewood with both of them, which one will break down fast? Obviously, the Mercedes will break down faster. Meaning, if you subject it, that person's family history, you're going to overwork the pancreas and come down. But now, doesn't mean that Hilux will not break down later. It might take us 2 or 3 years later to break down. So the taking of sugar, please, should be minimal. Can the patient eat with fufu, semo, right? Please, issue of fufu, remove it entirely. Semo, take it down. Wheat, yes, you can accept it. Rice in small quantity, no problem. Because you don't say don't eat rice again, like in the olden times. Good portions will be very, very okay for you. So can insulin be stopped and patients converted to oral after achieving good glycemic control? Now it depends on what you mean by good glycemic control. A patient came with DKA or HHS in the hospital and is coming for the first time, patient can be converted to oral if it's going home. But now, if you detect any form of beta cell exhaustion, this patient, whereby long-standing diabetic that has exhausted the pancreatic function, the patient must be on insulin inevitably. Because you notice this patient, initially they'll be on 2 milligrams of glimepiride, 1 gram BD of metformin, sugar is controlled. After 6 or 7 months, you see that it's not controlling, you throw in another 4 milligrams and 1 gram, now become controlled. And eventually it keeps on going. Next thing, add another glutathione or add a DAPA. Now, all this is telling you that the pancreas is going down, it's becoming exhausted. No matter what you do, you're working the pancreas. The earlier you add insulin, the better for you. So that the patient will have a very good outcome. Next question by, what's supposed to be calling them? What's the new question? Is there any contraindication to use of glucose lowering agent as against insulin displacement of diabetes? not protect the patient. Just know when to bring it. So what I mean by this is if patient needs insulin, if the patient can correct or can accept use of insulin, because as a patient, people you can spend the whole week telling them about insulin, oh, they can't force them. You ask them to do this thing. Also, okay. You also ask them to do this thing, to use the insulin, to use the OHS. So that's basically what it is.
What's the role of statins?
Role of statins in managing dyslipidemia in DM. How long do they need? To be honest, I'm seeing stations. In short, Coyote, for this, I'm not answering this question. What if stations? Statins. Where is the start? Please, like we said, we have a target to achieve, and diabetes itself is a metabolic, causing metabolic issues, especially with fat, can give you this lipidemia. So we need to be doing regular, like I said, 3 monthly check for this patient to be on statins. And statins, as you know now, the way it works, inhibits synthesis of cholesterol. So that's basically how it works. So you need to, so not only oral, you have to also manage the intake of these patients. Okay, yes, when fasting blood sugar is normal, HbA1c is high, should medication be started? Yes, this is a normal finding, yes, most times. But first of all, you need to validate the HbA1c. Because you have problem with HbA1c. One, you have issue of the calibration of the machine. Two, issue of the individual's blood, because you know it's red blood cell they use and his life what about it of red blood cell. So anybody that has any blood issue that either increases the red blood cell or reduces the red blood cell or changes the type of red blood cell you have, HbA1c is affected. Please, you should consider that in making a diagnosis of diabetes. So we have setbacks with HbA1c, but in such situations, you can do a pancreatic function test, which is the OGTT for borderline, whereby you subject the pancreas to a direct stimulation with the glucose so to find out what it is. But you can have normal fasting blood sugar and have high HbA1c. That one is sacrosanct, especially people that are non-diabetic. HbA1c, the problem there is basically, depending on the level, is postprandial glucose excursion. So that's why you should take care of that one. Fasting can be good and you can have high HbA1c. So, and we have a lecture on dietary modification in diabetes. As a matter of fact, that will be done by a dietitian. We hope to put it up very soon. Should it be done compulsorily before starting metformin for newly diagnosed? Very, it must be done compulsorily. But now, not basically metformin. Metformin can be used up to stage 3 of diabetic kidney disease, but you need a baseline to know how to approach and then what to avoid in treatment of this patient. Please, a baseline, you must have it. Is there a time you stop medication and observe the patient? I hope you're not talking about diabetes. So. If it's diabetes, please, you don't stop and observe. Please. Abubakar, I'm begging you, do not stop anything. Observe. By the time a patient is presenting with type 2 DM, the pancreas has gone by 50%. So you should know that one. So that's what I'm observing again. Please highlight on dietary modification, what to eat and what not to eat. Like I said, it's not not treating diabetes treatment today. We are giving overview how to manage these patients. Diabetes managed in pregnancy, same use of insulin, and please always refer the patient to a specialist if it's out of your purview. Please, but start patient on insulin. How do we commence insulin management of patients? When there's need for it, you know how to do that. Please recommend low. It's for a dietitian. We are looking forward to that. Some people don't like the idea of being on drugs for life and believe that dietary control and lifestyle changes alone can control their blood glucose. Yes, they always say this thing. And let me add for you there, they say that they are borderline diabetes or pre-diabetes. So such patients, there's no problem. Just advise them that the complication that will come with these things might be fatal that they cannot control. please, that they should take their blood glucose regularly, because inevitably, dietary control alone cannot control diabetes. It must give sensitizers, it must give secretagogues to manage this patient. So it's about the last question. I hope all your questions were addressed. Let me know if I missed anyone, because this is a serious issue. Like I told you, the idea of this is to manage patients like a boss, the way you manage diabetic patients. So please, any other question, bring it on before my other co-hosts will say one or two things. Our people are very spiritual, and this is very important in any chronic care. It's important to assess patients' spirituality to avoid problems. Yes. First of all, I want to make you understand that this, our knowledge is not from the devil. It's from God too. So we are so spiritual too. So now, I don't know if the God that gave us the knowledge to treat this thing and this drug development, I'm sure it's from God. So does it mean that you throw it away and now go and follow other things? Please, I think you should give to Caesar what is Caesar and give to God what is God. Please, if you're not saying you shouldn't go to church and pray and expect miracle to happen, but please always take your drugs, because even those who pray for you also take their drugs. I've seen them, I've been with them, I've counseled them to tell their congregants that please, that they should also take their drugs. So any other question? There's no other question. This is about the last question you have taken. So thank you very much for coming. Like I said, this idea of this position is for you to manage these patients like a boss. And with these few points of mine and my colleague, I'm sure that you have made some good points that you're going home with. So my name is Dr. CHUKWUNONSO. I'm a physician and an endocrinologist by training. And this is my colleague, Dr. Chima, Rupert, and we are all diabetologists. Thank you very much.
Okay, thank you everyone. Thank you for joining. It was an interesting time, and we appreciate you all for staying with us to this moment. So I'll be talking briefly on Cardiocare Hospital and how you can refer to us. My name is James Emmanuel from the Public Relations Department of the Limi Hospitals. So to refer to us, Cardiocare is located in Abuja at number 5 Isaac Close. It's one of the members of the Limi Hospital Group. So to refer to us, you can go to cardiocare.ng/referrals and you send in your referrals. So thank you so much. And these webinars happen twice in a month. Join us for interesting topics. And I've also dropped the link to our WhatsApp group. You can click on it and join. You can click on it and join. So as you can see on the screen, we offer services in cardiology, interventional cardiology, endocrinology, and general internal medicine. We also offer advanced care in coronary angiography, interventions, peripheral angiography, interventions, kidney transplant and dialysis, advanced cardiac investigations also. And we now have some new services available. We now do open heart surgeries there. We do pediatric interventional cardiology also, and structural heart interventions. So do well to refer to us. You can reach me online. You can call. This is the way you can refer to us. You can send a standard referral letter on site. You can go to our email and send us an email to frontdesk@cardiocare.ng or b.omotadi@limehospital.org. And you can also reach us on WhatsApp. The numbers are on your screen. And thank you so much for joining this session. We hope to have more of you. So for our WhatsApp group, you can still reach out to me. You can call me on the number that is displaying on your screen now. The number that is displaying on your screen, you can reach out to me on those numbers. Thank you so much for joining with us. Thank you for having us. Thank you so much. So we hope to see you in our next edition of the Limi Hospitals webinar. Thank you and have a wonderful time. Thank you.